Nick Majerison here, and welcome to Top Med Talk. Time now for one of the talks taken from EBPOM 2018. It's Ramani Moonesinghe with SNAP, Sprint National Anaesthesia Project. Have a listen.
Top Med Talk.
The final speaker of this session, Professor Ramani Moonesinghe, Chair of Perioperative Medicine at UCL. Ramani came to prominence with a wide portfolio in risk and outcomes in the high-risk surgical patient. Moved to taking on some rather large national audits which came to prominence, and now moved into taking her QI expertise further with the PQIP data. Ramani today is going to talk about the SNAP work and perhaps how it informs our intensive care management and use. Thank you.
Thanks, David. Good morning, everyone. I'm going to ask for your indulgence so that I can embarrass two colleagues during this talk. So the first colleague that I'd like to embarrass is the newest Professor of Perioperative Medicine at UCL, and that is Professor David Walker. Congratulations. He found out about that yesterday, so that really is hot off the press. Congratulations. And the next embarrassment will wait until a bit later on. So I'm going to give you some preliminary fingings of a study that we ran in the United Kingdom and Australia and New Zealand just over a year ago. I'm only going to present UK data, but I'm going to give an overview of what we did and the reasons for doing it. And I know that Denny in particular has really set me up well for doing this. And really, I guess, overarchingly, this is a talk about complexity, of all sorts of different types of complexity, and also of success. So we all know, I think, by now, that today is the 70th birthday of the National Health Service, and it's something that we in the United Kingdom, I think, are very proud of, and I think in lots of other countries people are very envious of. But we are constantly under pressure. There are often very poor reports. There was more bad news in the press this morning. I thought, really, it's our birthday. Can't you give us a break for one day? Nevertheless. And these are the sorts of things that we've seen in the news over the last year or two, and they include a lot of information about problems with critical care admission, and particularly also attributed to critical care admission for surgical patients. Now, the NHS is complicated, and the issues around perioperative critical care admission are complicated as well, as Denny has already alluded to. And some of the reasons for this are because healthcare in general and the NHS as a system is a complex adaptive system, and that is an official term. But if you break it down, it is complex because it's dynamic. The people are changing constantly, both recipients of healthcare and also people like us who deliver it. It is adaptive. It is capable of collective behavioural change and self-organisation, and that can be a really, really good thing, but sometimes also not necessarily such a good thing. And then the final thing is it's a system, and we all understand that, a set of things working together as part of a mechanism or an interconnecting network, a complex whole. But even at systems level, we can look at healthcare at different levels, and the social scientists in particular have come up with this framework for considering systems and contexts. So the macro level, which might be the national or the international level, the meso level, which is the local organisational level, and then the micro level, which is the individual teams within which we work on a day-to-day basis. And when you think about healthcare when it comes to perioperative care and critical care, you can think of the macro as the NHS, the meso as the trust or the hospital, and the micro as the perioperative team. Now, Denny's already talked a bit about guidelines. We're kind of awash with guidelines in all aspects of our practice, and nevertheless we seem to have trouble following them sometimes, and we don't know when it comes to perioperative critical care admission if the failure to follow the guidelines in a systematic, regular, reliable way is down to any of these factors. So some patients will genuinely be inappropriate for critical care. However they might look on paper, the end of the bedogram might say that they're not right for one reason or another. We may have a lack of capacity. We may not be able to risk stratify effectively, or there may be something else going on. And the something else has also been alluded to, this concept that in the United Kingdom, certainly, we define levels of care according to these 4 levels: a normal ward or level 1 care where patients might be at risk of deterioration, and therefore in the UK commonly they might be kept under observation by what we call outreach teams, critical care outreach teams. And then what we traditionally think of critical care as, which is providing some level of organ support or continuous monitoring. And absolutely fundamental to that is the level of nurse-patient support, the nurse-patient ratios. So in the United Kingdom, there's no clear definition for how hospital wards should be staffed. The government has really shied away from doing that. But for level 2 and 3, it's generally accepted that level 2 care, you need one nurse for 2 patients at a minimum, and for level 3, you need 1 patient and 1 nurse for each other. So staffing is a key aspect of the different levels of care. And as Danny has already alluded to, there's been a gradual move towards thinking about, actually, can we break these levels down further? Is there a sort of level 1.5 level that we can provide some aspects of critical care to patients, but not necessarily to surgical patients, but not necessarily all? So the aim of the SNAP2 EPICS project, SNAP standing for Sprint National Anaesthesia Project 2, EPICS standing for the Epidemiology of Critical Care After Surgery. These were the 3 broad aims. We wanted to analyse the epidemiology of critical care after surgery, who goes where and when and why. We wanted to use observational data to answer an interventional question, and I'll come on to unpick that in a moment. And a very important aspect of this was the citizen science approach. It was about engaging clinicians in research, particularly engaging junior doctors or trainees in research, and really getting everyone involved to get as comprehensive a sample as we could to answer these questions. So, breaking down the aims into a series of research questions or objectives, they relate to perioperative risk assessment, understanding capacity, and trying to unpick the question of clinical effectiveness. Does critical care admission actually make a difference to post-operative outcome? Taking these in turn, starting first of all with capacity, we wanted to understand here and now how perioperative critical care is organised in the United Kingdom. So in order to do that, and we also did this in Australia and New Zealand, we did an organisational survey. And in that we asked about the level of nurse-patient ratios on normal wards and what their normal practice was. Also what they did on their intensive care units, how many beds they had in the hospital, what specialist services they had. So we got a picture telling us about every hospital that took part, what they did, how they did it, whether they were specialist hospitals or not. And then we tried to get to the basics of the level 1.5 question by asking some of these questions. So looking at overnight recovery facilities within the theatre complex, and then looking to see if there were these little 1.5 HDU type wards sprouting up on normal surgical wards, to see what the level of support that was provided within those was and what the variation was between hospitals. Perioperative risk assessment, we've heard a lot about that today, and yesterday I hope everyone has read or will read the MET study, which is very important for this. So we wanted to understand how we actually do risk assess patients in practice, what do we use to help us in risk assessment, and how good are we at this. And again, sort of reiterating what's already been said, there is a case that there are high-risk populations that can be defined by the type of surgery, their age, and so on. But there is also the case which relates to this concept known as the Rose paradox or the prevention paradox, which means that if you have a high-risk population, that's usually quite a small population, and therefore the absolute number of patients that are in that population will be low. So to put that a different way, this is data from another Rupert Pearce study which used administrative data, so hospital episode statistics, just to try and help us understand how many operations we do in the UK, and it was led by Tom Abbott, who was a PhD student with him at the time. And I'll just draw your attention to this column, first of all. It looks at types of surgery according to complexity, minor through to complex major, then the number of procedures per year in each of those groups. So you can see, if you just look at the top line, over 2 million minor operations taking place per year, but only 200,000 complex major operations. And then you look at the total number of deaths in those groups, so nearly 200,000 deaths occurring within 30 days of a minor procedure, but only 25,000 deaths occurring within 30 days of a complex major procedure. Now, that is really extraordinary, I think. And there's a lot more underneath all of that than just the Rose paradox. There is stuff there about patients having interventions in the last 30 days of life. Some of them might be diagnostic, and then a decision is taken to palliate a patient, for example, with an obstructive bowel tumour. But nevertheless, there is some interesting stuff for us as perioperative physicians to look at in that, and I don't think that we've done that yet. Anyway, back to risk prediction. So we need to find a way to predict which individual patient standing in front of us is at risk of harm, and therefore what we should do to them. to try and prevent that harm. And the MET study I've already briefly mentioned, this was published in The Lancet last week, led by Daminja Wijesundara from Canada, but Paul Miles, Mike Grocott, Rupert Pearce and others are very involved in it. And I don't want you to read the detail of this. I just want you to look at this column here. This looks at different ways of predicting risk of adverse outcomes after surgery, different tools and different outcomes. And this is the area under the curve statistics. So the area under the curve, the maximum you can get is 1, which means that 100% of the time that tool will predict whatever outcome it is with 100% sensitivity and 100% specificity. 0.5 means it's no better than a coin toss. We would generally want to put our faith in tools that have at least 0.7 or 0.8 or greater of an area under the curve. And actually, I think these results are pretty underwhelming. So we may have a problem with actually which tools we should be using in what contexts. Now, this is not fair to say that these tools are not good because it didn't take into consideration the type of surgery that patients were having, but I think it's true to say that any measure of physical fitness, patient comorbidities and so on needs to be combined with a measure of the surgical severity and perhaps urgency as well. So, what did we do to address these questions about whether or not we can risk stratify appropriately? We did a 1-week cohort study in the UK, Australia and New Zealand, and we included as many patients as we could who stayed overnight in hospital for their operation. So we had broad inclusion criteria, all patients undergoing inpatient surgery requiring the support of an anaesthetist. We only excluded ambulatory surgery, patients having diagnostic imaging only, organ donors and so on. Very, very importantly, this was a non-consenting study. So in the UK, we went through quite a painful process to get permission to collect patient-identifiable data without patient consent. Patients had the right to opt out if they wanted to, but I can't think that any patients actually did. And this is really, really important because it gets over the problems that we sometimes have with trials or studies where we get recruitment bias and therefore we don't know how generalisable our results are. So hopefully the results of this study will be generalisable, at least to a general UK population. And to address the risk stratification question, this is a screenshot of the case report form that we used. We asked clinicians to estimate what the perioperative team thought the risk of death was for the individual patient in front of them, and then we asked them to tick how they came to that decision using all of these different tools. And the outcomes that were measured, several outcomes were measured. The primary outcome for the primary inferential analysis, which I'll come on to in a moment, was composite measure of morbidity, the post-operative morbidity survey measured on day 7 after surgery, and a bunch of secondary outcomes, including some that we measured directly at the time, so death within 30 days in hospital and death within 60 days in hospital. But also in the UK, we're linking to national data to understand longer-term outcomes and survival. We also wanted to understand a little bit about clinician attitudes and behaviours because it's clear that some hospitals will prioritise different patients for critical care admission and some individuals will. So we in this room, whatever the guidelines might say, will all have different opinions about this. So we thought we would do a survey asking clinicians who were working during the week of the patient study about what they thought about critical care admission, describe their attitudes towards it, understand a little bit about their demography so we could look at differences in medical specialty, age or years of experience of the people answering the questionnaires, and how often people use different risk prediction tools. And then finally, we wanted to try and get towards answering the clinical effectiveness question. So does critical care admission after surgery actually make a difference to outcome? And we chose to answer that using our cohort study. And you might ask why we didn't do a randomised controlled trial, because actually the way to really answer a question about an intervention is to test it against a placebo or another intervention. But we didn't feel that we could do an RCT for 3 main reasons. The first is that we didn't think it was ethical, and we surveyed a few people to find out if they agreed with us, because there are guidelines out there telling us what we should do, whether we do it or not, and we would think that quite a few clinicians would not believe that they had equipoise on the question to be able to take part in the study. For that reason, and also because we hypothesised that actually if you randomly allocated patients to critical care, we may not actually have the capacity to admit all those patients to critical care, we didn't think that it was a feasible study to do. And the final reason is because we didn't feel it would necessarily be representative, particularly if we needed to seek patient consent. But the final reason is we weren't really sure at that time, and I think we might be getting a bit nearer to it now, about which group we should be looking at. So it's clear that you wouldn't look at, for example, 25-year-old patients having dental surgery and randomise those patients to critical care or not, because clearly they don't need it. But which patients should we be looking at? What is our cohort? So lots of studies have used patients over the age of 40 having major surgery, but even in those studies, the outcomes are better than necessarily predicted beforehand. So we hope that through doing this cohort study, we might get a bit closer to the question of which group we should be looking at in more detail to determine the clinical effectiveness of critical care, and therefore possibly, if we haven't answered the question, using some fancy stats on our cohort to do a randomised trial later. And we are doing some fancy stats on our cohort, and these are called causal inference statistics. So in a randomised trial, you all understand that we randomly assign patients to an intervention or control on a coin toss, effectively. There is a method called instrumental variable analysis, which essentially you find an instrument which is a random event which doesn't affect the outcome except through modifying whether or not the patient gets the intervention that you're interested in. And in the case of critical care admission, we hypothesise that the occupancy of the critical care unit would be a key determinant of whether or not a patient on one day went to ICU after their surgery, and on the next day the same patient might not, because on the second day if the unit was full, which is basically a random event, that same patient might not get in. And then finally, we wanted to know what makes us refer patients for post-operative critical care. What are our thresholds? What do we actually do in practice? And what on the ground decides whether or not patients go to post-operative critical care? So we can decide in good faith that they should go there, but if a trauma case comes in and takes that last bed, the patient's going to get bumped. So what's the reality out there on the ground? And when thinking about how to do that and the questions that we would ask in the cohort study, I was giving a presentation to this group, which is a small society of intensive care consultants and trainees in the southwest of England. And when I was telling them about the ideas for this study, they said, you're not going to get a complete answer to your question unless you understand whether patients are cancelled or not because they can't get into critical care. And that was something that actually hadn't really occurred to me before then. So I'm grateful to SODIT, as they're known, for their intervention to improve the quality of the trial. And as a result of that, we saw also an opportunity, because by asking a few questions around cancellations, both at patient level and at hospital level, we were able to determine what the last-minute cancellations of surgery, what the reasons for that were, and what the rate was. And politically, that's a very important story in this country. So, the cancellations data, we looked at two levels. We looked at organisational level. We asked our local principal investigators to do a census on a daily basis to tell us about the number of inpatient cases that were cancelled and the reasons why, so simple counts. And at patient level, for every patient that was recruited into the study during the week, as part of the CRF, we asked whether or not they had been previously cancelled and the reasons why. And because we had a lot of detailed data about those patients, loads of risk factor data, demographic data and so on, we were able to understand both patient and hospital level risk factors for cancellation. So today I'm going to present to you the highlights of the organisational survey, and for the first time we're going to present the results of the cancellations data, which has now been accepted for publication in the British Journal of Anaesthesia. So early results, UK data only. So this is a flowchart showing you how many hospitals in the UK took part. 263 hospitals were invited. So this is all hospitals that undertake inpatient surgery in the NHS. 6 hospitals declined. 12 hospitals didn't take part in the main study. So in the main study, 245 hospitals took part, but there was 257 hospitals took part in the organisational survey. And in the main study, nearly 23,000 patients were studied in that 1 week. This is a plot showing the number of inpatient beds on the x-axis against the number of cases recruited on the y-axis. And you can see it's a nice straight regression line with only 2 outliers. And what this basically means is that every hospital that took part probably gave us all the data. So that is a real achievement. And not only did they give us data on every patient, we believe, but they also gave us 94% complete case report forms. Now, this study basically cost very, very little. We had core funding from the Royal College of Anaesthetists, and I'll thank all the funders in a moment. We had some funding from the Association of Anaesthetists, which paid for a salary, which I'll come on to in a moment. But all the hard work has been done by the chap here on the left. So this is Danny Wang, and I know where he's sitting. Danny, can you stand up, please? Can we have a round of applause? That's his wife looking happy before he'd started his PhD. So Danny did a huge amount of work, also other staff who I will thank at the end, but this really, really was a great success for citizen science. The organisational survey, the top-level results, I'm going to encourage you to look. This is a breakdown of data from the 4 devolved nations, but I'll encourage you to look at the left-hand column, which is the overall results for the UK, and particularly down here at the bottom, so the number of critical care beds per 100 beds, so less than 3 critical care beds per 100 beds in the hospital. 2.3% of beds were PACU beds. But what was interesting is that there were 72 enhanced care wards, so level 1.5 wards, declared by the 257 hospitals that took part. So 28% of hospitals have an enhanced care facility, which is really interesting because this is an organic process that has happened. And if you look at what is being provided in these enhanced care settings, so the patient-nurse ratios are about 2.5. Most of them provide continuous monitoring, but that could be non-invasive monitoring, so saturations, ECG, and so on. 2/3 of them have the capacity to look after an epidural. Nearly 2/3 look after invasive arterial line blood pressure monitoring. Just less than half can provide vasoactive infusions. 1/3 provide CPAP or NIV, and a very small number, 5%, provide IPPV, so invasive ventilation. There's a good lot of critical care going out there in a setting which is not traditionally considered to be critical care in this country. And then when you consider this, which is the responsible consultant for those units, you also start to get an interesting picture, which I can tell you our Faculty of Intensive Care Medicine is very interested in. So these units are predominantly looked after by surgeons, not anaesthetists, not intensivists, and so on. And as I say, these are units that have clearly grown up organically because the hospitals are trying to meet the challenge of not being able to provide critical care after surgery. And I'll come on to more data which supports that in a moment. So what is the prevalence and what are the determinants of late surgical cancellation? And this is very politically expedient at the moment. So the big headline here, so first of all, the flowchart again. For this analysis, we only looked at elective and expedited surgery. These are NC-POD classifications. Elective is completely planned, so that will be your joint replacement, for example. Expedited is surgery that occurs within usually a few days or weeks of the decision to operate. So that might be, for example, an urgent cancer treatment. That 23,000 patient cohort got knocked down to about 15,000 patients looking only at those. And they came from 93% of NHS hospitals. So again, a very, very comprehensive representative sample. So the big headline is 1 in 10 patients who had data collected on them during the study had been cancelled at least once. 1 in 10 having major inpatient elective or expedited surgery had been cancelled at least once. And when you look at the reasons for cancellations, the principal reason that patients were cancelled was clinical reasons, and I'll come on to explain a bit more about that at the moment. And the second reason was lack of beds, and then insufficient operating theatre capacity and so on. So more than 50% of cases that were cancelled at the last minute were cancelled for non-clinical reasons. The biggest single reason that patients were cancelled was clinical, but most patients were cancelled for non-clinical reasons. What is a shame, and in retrospect, we should have unpicked this further, we don't know whether those clinical reasons are because the patient turned up on the morning of surgery with respiratory infection, or we don't know if it was because the patient's warfarin wasn't stopped. And it's a shame that we didn't collect that data, but if we do this again, it would be interesting to find out. And then we looked at both patient levels and hospital levels, so using hierarchical modelling, at what the independent risk factors were for late cancellation on these patients. And I don't know how well this projects, but the significant effects are the ones in strong bold. To the left, it's protective. To your left, it's protective, and to the right are risk factors for being cancelled. So on the left-hand side, If you were having cancer surgery, you were much less likely to be cancelled. The odds ratio was 0.32. If you were having obstetric surgery, and I should say that obstetric surgery was just planned caesarean sections, then you were very, very much less likely to be cancelled. If you were having expedited surgery, so that's your more urgent cancer type of surgeries, you were much less likely to be cancelled. If you needed postoperative critical care, you were much more likely to be cancelled. And then if you look at the hospital level effects, so what is it about particular hospitals that might predispose patients to being cancelled at the last minute? Having an emergency department in the hospital was the biggest risk at hospital level for patients being cancelled. And interestingly, having an enhanced care ward was also a risk at hospital level for patients being cancelled. But I think we can all see the reasons why that is. These hospitals are probably trying to address the issue, but haven't quite got there yet. So what does this all tell us? What is our interpretation of this? What do we know now? We know that critical care is a complex intervention. It's not just a place of safety. People go there to have different interventions, but we don't know which ones necessarily we should be offering. And so as a result of that, hospitals are self-organising in an adaptive way to try and meet what they believe to be the needs of the high-risk surgical patients. So they are organising these small HDU-type units where they are providing a variety, a mishmash of different interventions, and there doesn't appear to be a huge amount of consistency about how these units are set up, which is unsurprising given that there are no guidelines to try and help us with that. Hospitals probably have different thresholds for admitting patients. So I would hypothesise, we haven't looked at the data in this way yet, but I would hypothesise that hospitals who believe that more patients should go to critical care have organised themselves into these level 1.5 units, and we might see a difference in their clinicians' perception survey results at hospital level, which reflects this. A third of cancellations are for clinical reasons, and as I said, it's a shame that we can't unpick whether that was short-term clinical or longer-term potentially preventable clinical reasons, but that is something that we need to look at further. The requirement for critical care is a risk factor for the cancellation of planned surgery, and this is a big deal because we don't know if critical care is an effective intervention for all the patients that we try to get there. So it is possible that some patients are being cancelled unnecessarily, and even if that doesn't cause harm to them in a physical way, it's highly likely that it causes harm to them in a psychological and potentially an economic way if these are patients who are still working or have got kids or whatever and have planned their lives around their surgery, which is then cancelled. So what are the solutions to all of this? Well, I think we need to understand a bit more about level 1.5 care. There's a working party that's been set up by the Faculty of Intensive Care Medicine, which Mike Swart and I are on, which will be looking at this exact issue. Do we need to, and here's something just to throw out there, do we need to think about reconfiguration of services? The odds ratio for being cancelled in a hospital with an ED was 5 times as high than hospitals without one. And that's kind of obvious. I could see people nodding in the audience. So do we need to think about reconfiguring services to split out elective and emergency care? And on that theme, do we need to think about ring fencing of beds? You're going to hear a talk this afternoon from Mike Swart about the Getting It Right First Time initiative for perioperative care. There have been several Getting It Right First Time reports published by different surgical specialties, and orthopaedics and cardiothoracics have both called for the ring fencing of beds for their specialties to avoid cancellations. And you could argue that these data support looking at those solutions, at least modelling them mathematically to try and see if it would solve a problem. If you look at the obstetric example, where obstetric patients were very, very unlikely to be cancelled at the last minute. Now, there's clearly clinical reasons why that might be, but there is also the fact that obstetric units are basically, usually in this country, they run on their own, they have their own HDUs, they run almost independently of every other service. So maybe that tells us something. Some teasers for the rest of what's coming. 48% of clinicians use their own clinical judgment alone to decide about how high-risk patients were. So we're going to be able to compare existing risk prediction tools and clinical judgment in a really large unrestricted sample. The next steps for this are to link the data with long-term outcome data. We might go back to some hospitals to find out a bit more about the enhanced care stuff. And then there's the clever statistics stuff, which I'm glad that I'm not going to be doing, but Danny and Steve, our other main collaborator, are. So finally, grateful thanks to Danny, Steve, Laura Farmer, who was the administrator at the Royal College of Anaesthetists, James Goodwin, Jose Lorty, who's sitting there, who were the members of the project team, also the steering group, which was chaired by Mike Grocott. And finally, I talked about the complex adaptive system, the system bit, a set of things working together as parts of a mechanism, an interconnecting network. So this was only possible because we work in the NHS, because 2,800 people gave up their time to collect the data. These are some of the photos. They did it for no money. They did it because they wanted to. Happy birthday.
And don't forget you can meet the Top Med Talk team. All you need to do is turn up at one of our events. Check out ebpom.org for more details. ebpom.org.